Dear colleagues, good afternoon, all of you, and welcome to the spring webinar organized by the EFIM Multimorbidity Working Group. I'm very glad to be here, and I'd like to thank Professor Maximo Bernabeu-Whittel, all the members of the group and the organizers for giving me this opportunity. I will briefly introduce myself. My name is Ombretta Para. I'm an internist from the FADOI, that is one of the two Italian scientific societies of internal medicine. I work at the University Hospital of Careggi in Florence, and for the past 5 years, I have been a hospitalist in emergency surgery and neurosurgery. Today, we'll discuss together a topic of a great interest and relevance, the role of the hospitalist in the management of patients with comorbidities in surgical settings. In organizing this webinar, we started from a question: why do we need a new organizational model in surgery? We know that the surgical patient is increasingly elderly, affected by multiple comorbidities and in polypharmacy. And these comorbidities may worsen during the perioperative phase. Furthermore, we know that chronic disease can flare up in the perioperative phase, requiring the frequent involvement of different specialists in medical disciplines. So we have the need to identify new organizational models based on the interaction of internal medicine and surgical expertise for a comprehensive assessment that takes into account the patient's fragility and complexity. So today, we'll try to explore this topic in more depth. Our webinar is organized in this way. There will be 2 lectures followed by a discussion. Now my time as a chair is running out, so with great pleasure, I leave you with the first speaker, Professor Francesco Dentali, who is the president of the FADOI. Francesco Dentali is Associate Professor in Internal Medicine at Insubria University, and he has extensive experience as an international researcher and serves as Director of the Department of Internal Medicine at the Circolo Hospital in Varese in Italy. So let's start our travel through different co-management models in surgical settings with Francesco Dentali. Thank you, Francesco.
Thank you for this presentation, very kind, and thank you very much for having invited me in this important and interesting meeting. I will try to share my slides. Just a moment. Okay. And I think this is the first slide. So I'm not a super expert, but I think that co-management is very, very important. And we are trying, as Ombretta suggested, we are trying to run out this different model in the management of our patient. These are my disclosure. I have no any conflict, financial, non-financial conflict of interest to declare regarding this presentation. And this is the starting point. The co-management is a topic in the center of our attention as EFIM committee. This is a paper published by our working group at least 6 years ago, and we try to, in that paper, we try to improve the quality of perioperative care. Why we publish this paper? Because in surgical patient, the incidence of complication is not negligible. For instance, in this large study published 20 years ago, the incidence was more than 15%. And as we can see, there are cardiac and non-cardiac surgical complications. In this study, almost 4,000 patients were enrolled, and as you can see in the slide, many of these patients, in special patients with complication, have many different non-surgical comorbidities, such as diabetes, hypertension, or previous ischemic heart disease or cerebrovascular disease. So the topic of management of comorbidities of non-surgical comorbidities in surgical patient is a very hot, important topic. As you can see in this other slide, the incidence of complication is during the perioperative time, and many complications occur even after 5 or 6 or 7 days after the surgery. So the problem is not limited to the 24 hours before and 24 hours after the surgery, but the problem is a problem present during all the stay after the hospital stay after the surgery. And it's important to see that we can have many different complications. For instance, myocardial infarction, but also other kind of complications like infection or confusion or problem with respiratory failure, deep vein thrombosis, and so on. So we need a specialist that could manage every kind of comorbidity and could manage every kind of complication. The other thing that we could ask if we have one or more of this complication, how this complication could impact on hospital stay. And I think that this slide is quite explicative, because we can see that the length of hospital stay is quite short in patients without any complication, and become longer and longer if we have cardiac or non-cardiac, or cardiac and non-cardiac complications. So we should avoid the occurrence of this complication. This is another important study on patient hospitalized and with a surgical problem in US, and we can see that they divide different hospitals according to the mortality rate, starting from a very low mortality rate and arriving to very, very high mortality rate. And the mortality rate varied in an important manner in different hospitals, ranging from less than 4% and to almost 7%. And we can see that the incidence of complication is very high in all the different kind of patient. About 1/4 of patient had one or more complication, and about 1/5 or 1/7 had a major complication. And the incidence of complication is not different in hospital with different mortality. But, and this is the important part of this study, the mortality rate is higher when we have a major complication. In particular in hospitals in which the mortality rate is already very high. We can see that many different kind of complications are associated with mortality. For instance, pneumonia or bleeding or infection. You can see in this slide deep wound infection or organ infection. And again, the specialist that could care all this kind of complication is not the surgeon, but is an internist, because many of these complications are medical complications. And arriving at the point of my presentation, we could have 3 different models of care for management of surgical patient, of medical management of surgical patient. The first one, the easiest one, is the consultation, and the second one is the medical surgical co-management, and the last one is the perioperative internal medicine unit. In some hospital, in some health system, we have a specific perioperative internal medicine unit. But in many countries, this kind of organization does not exist. So I try to concentrate more on consultation and on medical surgical co-management. Consultation is the easiest one, as said, and we should not under consider this kind of medical act, because it's very, very important. But we know that we should perform a consultation in a proper way. Almost more than 40 years ago, Goldman, Lee, and Rudd published this important paper that is the 10 Commandments of Effective Consultation. And they suggest 10 principles of consultation. You can read with me. The consultant should determine the question that is being asked, establish the urgency of the consultation, gather primary data, communicate as briefly as appropriate, make specific recommendation, provide contingency plans, understand our own role in the process, offer educational information, communicate, because communication is very important, communicate a recommendation directly to the requiring physician, and provide appropriate follow-up. And they suggest that to perform an effective consultation, we should follow these principles. But we know that effectiveness is different for us and for surgeon. What is very effective for me is not effective for a surgeon. And in this study published more than 20, almost 25 years after, we can see that surgeons consider other topic more important for an effective consultation than the topic that we consider as internist. And after this survey, Salerno and collaborators suggest a revised version of these commandments. You can see the slide and the reference. I will not read all the recommendation because I don't think that I have to use my time reading, but try to explain the different models. And the other topic, important topic, is not only what is important for us as a clinician, but also what is important for a patient, and this is a very important topic. This study is a kind of survey in which they ask what is important for clinician and what is important also for patient. They try to collect information. And I think that this slide is very informative because they underline the role of information exchange. When we perform a consultation, we should have the proper information from surgeon, proper information from chart, but also we should speak with patient and should inform patient on what we are doing and what is the plan of our consultation. So even if we are convinced that we are very effective, as we can see in this other slide, the consultation is considered effective and clear in less than 50%. In this survey with 15 family physicians involved, you can see that less than about 40% of the consultation discussed were considered clear. In another 40% of cases, communication was considered confused. And in the remaining 20%, there was even a conflict. So I think that this is a very, very. We should reflect on this small study. And this is another study, and if the communication is confused and we are not convinced about the consultancy, what is the result? The result is explained in this study, in which you can see that the compliance on the recommendation of the consultant is low. It's very low, and lower than the rate we believe sufficient. In moderately ill patient, less than 70% of recommendations were followed. And even in severely ill patient, only about 81% of recommendations were followed. And this problem is particularly true for a recommendation about diagnostic test. Is better for treatment and is very low for diagnosis. And also is different when we make some recommendation. We talk with other physicians, or we talk with nursing staff. And you can see that in this study, only 60% or 70 at a maximum of 70% of recommendation were followed by nursing staff, even in severely ill patient. And I think we should reflect on the role of consultancy in this patient. This is another study, and I think also this study is important because they try to divide formal and informal recommendation. We are convinced that formal recommendation were followed better than informal recommendation, but if we look at this study, this is not true. This is not true. Even a formal recommendation were followed only in a part of physician, by a part of physician. Again, if the recommendation is about treatment is better, if the recommendation is about performing a diagnostic or test or monitoring, is lower, is worse. So recommendation is not very effective in general if the recommendation is made by a physician that is not a part of the unit, of the keep of the surgeon. So, summarizing this part of my talk, we could ask ourselves, it's my cat, is medical surgical consultation effective? And this is a systematic review summarizing all the high quality evidence on the effectiveness of consultation. And these are the results. We have not any high quality study. So we don't know if a consultation is an effective way of doing medical surgical co-management. On the other part, we could ask ourselves, is medical surgical co-management effective? And the answer is completely different because there are some evidence and there is at least one good systematic review. This is the review by Shaw, published 4 or 5 years ago on about 8,000 patients in different surgical settings. And you can see that if we sum up all the results, we have a lower length of hospital stay, 1 day. 1 day is not a spectacular result, but is a result. And if we look at the different study, we can see that in some study the difference is very important, 7, 8 days, and in other studies not is negligible. So probably in different setting, the role of co-management could be different, but we don't know the quality of all these included studies. This is another endpoint, 30-day readmission, and again, the 30-day readmission is lower, but it's not significantly lower, because there are some important difference among different studies. And the same is true for in-hospital mortality, in which we can see that there is a difference, but this difference, again, is not significant. So we should try to look at original studies. For example, in this study on orthopedic and neurosurgery patient, they compare results without co-management. And results are quite interesting because if you look at the subgroup analysis, you can see that for more comorbid patient, the results are better. We have better results. So probably we should select patient in which co-management could be useful. And the other topic is we should try to select in which setting, the setting. For instance, in this case, this is a study by our moderator, they sum up results of patient treated with co-management or without co-management in general surgery patient. And we can see in this study that is the rehospitalization rate is completely different. Is almost 12% in patients in which co-management is not implemented, and is 4% in patients in which co-management is implemented. And this is another study in a neurosurgical patient. And again, the rate of complication is completely different. So these are my last two slides. Who is the attending physician responsible for the co-management? We saw that the consultancy way is not a good way, and probably we should go to the surgical medical co-management. But who is the physician? In US, the role of hospitalist is prominent. We know that every kind of health organization is different, and they have this specialty. But if you look at this editorial, you can see that many of the hospitalists are doctors specialized in internal medicine, and in this editorial they underline the holistic approach of internal medicine. So again, we are the specialty that could manage all these kind of comorbid patient. These are the characteristics of a perfect hospitalist. And again, you can see that all these topics are topics followed by internal medicine, or topic in which doctors specialized in internal medicine have some capacities. In conclusion, we have different models of non-surgical care of surgical patient. There is limited evidence on the efficacy of consultation, and we have better evidence on the role of medical surgical co-management. But we have many but, unfortunately, that are not compelling. The evidence are different in different settings, different surgical settings. And in original study, the endpoint considered is different. We don't know if co-management could be effective in reducing mortality, or in reducing complication, or in reducing length of stay. And the last point is cost. we don't know if there are no high-quality evidence suggesting that medical surgical co-management could be cost-effective. We are pretty sure that we could reduce complication, but adding a new physician to an equipe could be costly, and we need other studies about this topic. Thank you very much.
Thanks to Professor Dentali for his clear and interesting lecture. We can discuss some topics together later. And I remind the audience that you can use the specific section on the platform to write your questions for the speakers. Let's now move on to the second lecture, which will be given by Professor Arantxa Álvarez de Arcaya Vicente from Spain. She is the Associate Professor of Medicine. She is coordinator of the Spanish Society of Internal Medicine for the Relationship with Patients, advisor of Working Group of Co-Management and Hospital Medicine of the Spanish Society of Internal Medicine, and she is a recognized expert in the field of hospital medicine. Today, she will talk to us about managing relevant diseases and medical complications in patients with multimorbidity. Thank you for accepting our invitation, and the floor is yours.
Thank you very much. I think it's correct, yes. Thank you to the organizers and, of course, to Dr. Bernabeu and Dr. Para for inviting me and give me this opportunity. My name is Arantxa Álvarez de Arcaya, and this is a summary of my professional background. I have no conflicts of interest, and this is my schedule of my speech. First of all, why this topic is relevant for internists. There are several reasons for this. The first is that life expectancy has increased. We are seeing more and more patients over the age of 65, and it is increasingly common for them to over 80. There is a high need for surgical interventions in this age group, and the development of new anesthetic and surgical techniques with successful outcomes in this population. So the multidisciplinary management of these patients, in which internists play a coordinated role. And furthermore, these patients are informed patients who want to take an active role in decisions about their illness. In this slide, we can see the evolution of the population in the European Union. The data comes from Eurostat, and it is estimated that the average age will increase by 6 years between now by the year 2100. And the rate of dependent people also will increase from 25% to 60%. And at the present, in 2023, 1/3 of the European population has a chronic disease. Age by itself is not the only determining factor for additional surgical risk. Key factors include the presence of multimorbidity, the functional status, and frailty. Multimorbidity is becoming more common due to factors like aging, lifestyle lifestyle changes, and improved diagnosis capabilities. Multimorbidity is more prevalent in older ages, with rates rising between 45% for those aged around 60, 65 to 70% for those around 85 years old. Another key reason why this is relevant for internists is hospital organization. I like these pictures because, and I use it often because it reflects hospital organization. The hospital system itself, a structure that is hierarchical and departmental, where communication and collaboration often fail to flow. However, this often results in poor communication and uncoordinated decision-making regarding process, and most importantly, regarding patients. And the third key point is the environment. The influence of the environment is real. It has changed compared to just a few decades ago. We must take into account diversity, the concept of One Health, the environment medicine, and the great social complexity. But in this context, the essential elements are these three aspects. Multimorbidity is increasingly prevalent. Nearly half of surgical patients have more than 3 chronic conditions, which increasing clinical complexity and impacts outcomes. In this slide, I'm showing you the most common medical complications in the perioperative period. But in the end, it doesn't really matter what the disease is called. What matters is the presence of frailty in one hand and the disability in the other. Frailty is defined as a clinical condition characterized by reduced physiological reserve and diminished and increased vulnerability to stressors, and leading to adverse health outcomes. It has long been known that frailty is a significant predictor of surgical outcomes, and it is associated with higher rates of postoperative complications, prolonged hospital stays, increased mortality, and greater likelihood of institutionalization. The same with disability. Disability was defined by the World Health Organization from 3 aspects: the body function and structure, the performance of activity in relation to participation, and also we know, same like frailty, disability is an independent risk factor for adverse postoperative outcomes. So how should these patients be approached? How can we minimize the impact of surgical procedures in these patients? Performing a preoperative assessment, in which we evaluate these 4 domains: clinical and life expectancy, presence and severity of chronic disease like diabetes, heart failure, and COPD, for example, identification of the polypharmacy, inappropriate medications, potential drug interactions or geriatric syndromes, of course, the weight loss, body mass index, bioimpedance analysis, and so on. Another topic is frailty and physical function. Well, applying frailty scales or evaluated the ability to perform basic and instrumental activities of daily life. Of course, cognition and psychosocial factors, screening cognitive impairment or dementia, evaluated the anxiety and depression, and of course, the availability of caregivers, family and social networks, and the access of psychological support. Regarding all the patients, I like these flowcharts of Orizana, published in 2014, a long time, in which outlines the decision-making process for this age group, taking into account the risk-benefit balance specific for this group of patients. For all these reasons, it's important to assess the patient's surgical risks beyond the traditional way use the ASA scale. Here I present two articles that show how preoperative assessment by anesthesiologists and internists reduces postoperative mortality. So how can we evaluate the risk? This is the most commonly used scale to assess surgical risk, the ASA classification by the American Society of Anesthesiologists in 1963, I think. However, it does not take into account the specific risk associated with the surgical procedures itself. This slide shows the estimated surgical risk based on the type of non-cardiac surgery. And in this slide, we can see various risk assessment scales that take into account different aspects of a patient's health. The table presents a comparison of risk prediction tools for patients undergoing general surgery. Apache score is a postoperative tool used for critical ill patients. POSUM is widely used in the United Kingdom, but it tends to underestimate morbidity and mortality. The SORT score is simple to use, predicts 30 days postoperative mortality, and includes general patient information along with surgical procedures detail. However, it has not been formally validated. I like this score file. I would like to show the risk calculator developed by the American College of Surgeons. I like because it includes 21 items and predicts 30 days postoperative mortality, as well as cardiac and non-cardiac morbidity. However, is not validated for use in emergency surgeries. This is a specific scale for cardiac surgery. The most commonly used risk prediction score is in the European System for Cardiac Operative Risk Evaluation. This was developed in the late 90s, and it provides provides a robust assessment. The score is based on 18 clinical characteristics from 3 categories: patient factors, cardiac-related factors, and also operative-related factors. The score has been validated for United Kingdom, Europe, and also in North America, and predicts the major complication of this this kind of surgery. How internists prevent perioperative complication? For cardiac assessment, we usually use the New York Heart Association classification for functional status and the cardiac risk index to identify patients at higher risk for complication. The incorporation of Duke Activity Status Index score into the preoperative evaluation helps to improve the accurate identification of intermediate and high risk patients who warrant modification in perioperative care, using a cut-off of score around 34. We suggest the risk of the patients. In elevated risk patients, the authors now suggest assessing functional capacity with Duke activity, and for those with poor or unknown functional capacity, for example, with score industrial scale under 25 points, they recommend to consider the levels of the VMP to refine the risk estimation. Regarding to pulmonary assessment, ARISCAT score, I think, is the most common. It predicts a risk of pulmonary complications after surgery, including respiratory failure, and it considers patients' factors like age, preoperative oxygen saturation, anemia, and others, like you can see in the slide, and also surgery factors like the duration of the surgery. A chronic kidney disease before surgery is associated with higher postoperative complication rate and mortality. Patients with chronic disease are particularly predisposed to develop postoperative acute kidney dysfunction. But there is a valid scale to evaluate the risk of acute kidney injury, and there is a preliminary evidence that the serum biomarkers and BMP alone and the combination with the estimated glomerular filtration can add information to the risk of postoperative acute kidney injury patients. Patients with liver cirrhosis deserve special consideration. They are often complex cases with challenging postoperative management, and surgical risk is frequently overestimated. The MELD score commonly used is in this patient was originally designed for liver transplant evaluation. And when assessing surgical risk in cirrhotic patients, the vocal pen score can be used instead, and it predicts the risk of mortality and decompensation at various time points after hospital discharge. For Friede screening, we use two scales in our practice. The clinical Friede scale, also known as the Rockwood scale from Canada, is used in our case is used by surgeons because it is a simple and highly visual scale. And however, our comprehensive assessment include the Frail scale, the Frail index, along with, of course, clinical examination and other tools to evaluate the 4 key dimensions we saw before, such as the Bartley index, the Charlson Comorbidity index, for example. And of course, we perform the nutritional assessment, we evaluate functional capacity, and of course calculate the Charlson Comorbidity Index. So as internists, we must assess and optimize the complex surgical patient, anticipating potential postoperative risk. Rehabilitation programs are key to reducing medical complications in postoperative period, and we achieve this by conducting a thorough risk assessment and implementing proactive, early and targeted and fully personalized intervention plans. It's important to remember that these are the main components of the comprehensive preoperative assessment, in addition to the burden of chronic diseases and patients' priorities. These are the aims of rehabilitations: to prevent complications and avoid prolonged hospital stays. And we designed a care and treatment plan to improve outcomes, optimize recovery, and reduce complications. These include nutritional recommendations, like the quantity of proteins and the diabetes control, respiratory physiotherapy using Physios app and incentive spirometer. We prescribe exercise, not only the 150 minutes from a walking activity, we prescribe also strength training, adapt to different patients. And we optimize chronic conditions. We prescribe or prescribe, such as medication adjustment in chronic patients to prevent decompensation, of course, anemia management. And now I share with all of you our experience. Here I present some results from the patients included in our rehabilitation program. They are older patients, management by internist and a case management nurse, and then referred from different surgical departments. It is interesting to note that 15% of the patients assessed are not considered suitable for surgery at that time, Medical interventions focus primarily on optimization of chronic conditions, nutritional supplementations, and intravenous iron administration. The Northern intervention is aimed at health education, nutritional advice, and exercise recommendation. And we started this program in cardiac surgery a few months ago. In the preliminary results, we are seeing that rehabilitated patients have shorter hospital stays, fewer transferred to the ICU due to complications, and fewer prevent around 30-day readmissions. We can see on the left of the slides, and this is early data, but I think they are promising. This is the reference I use in my talk, and thank you very much for your attention. Thank you.
Thank you, Arantxa, for your very complete and interesting presentation. And we have just heard the lectures full of interesting insights. Let's now open the discussion session. I'll check right away if there are any questions on the platform. Okay, at the moment there are no visible questions on the platform. So I will start, and I will ask a question to Professor Dentali myself. Professor Dentali, today we are here to ask ourselves if the internist can be a central figure in these new organizational models. We recently conducted an European survey regarding the role of the hospitalist in Europe, involving all countries referring to the EFIM Society. Data from this survey showed that almost all the responders know what the hospitalist does, and most people believe that the most suitable figure to fill the role of the hospitalist is the internist. Moreover, most people agree that specific skills are important or even necessary. And this is the problem of the training hospitalist in the Europe. And I think that most skills are usually acquired on the field through daily tasks. And the topic of skills and training is still greatly underestimated in this field. And I believe that young internists must acquire competencies in multimorbidity and perioperative medicine during their fellowship programs. And I think that this topic is crucial. And the question is, what do you think is the best training method in this field? Where should these skills be acquired, and who should provide them? Thank you.
Thank you for this question. I believe this is the central issue, because the figure of the hospitalist specialized in co-management either or does not exist or is not clearly defined in many healthcare systems. So at the moment, as you said, internal medicine residency does not include a dedicated part on co-management or on perioperative medicine. And the problem is this: we should change our programs. We should include in our residency programs dedicate part on this topic, on co-management and on the management of comorbidities in surgical patients and in many different surgical settings. And also, I believe that scientific societies such as FADOI or EFIM and in national and international internal medicine society should also organize efforts to certify competencies related to co-management, because we should not wait for the change of residency program. Even if after the change of the program of the residency, we needed to certificate after the residency. So we should start and we should organize specific program for these figures.
Okay, thank you. I very agree with you about this point. And I have another question from Arantxa. Arantxa, European internal medicine is facing major challenges regarding medical resources. And in your opinion, how can hospital resources be best used so that internists can also take on the role of the hospitalist? How necessary are specific engagement criteria that would allow us to more accurately identify patients who should be managed by hospitalists?
Sorry, no.
Okay.
Thank you, Arantxa. This is a great question because in my country, we usually discuss about this topic, you know, between the co-management and the consultant advisors. Co-management means to see all patients since they were admitted to the hospital. But in my opinion, we have to select patients who would benefit most from our care, considering that the number of the doctors, in my country at least, is small, and the number of the patients are operated is growing each year. So I believe that in the practice co-management, we have to select patients and offering high value care, patient centered care, and practice oriented toward quality and safety. I mean, practice oriented to risk patient. We have different inclusion criterion in our practice according to the surgeons, different for cardiac, for example, cardiac surgical patients, thoracic surgical patients, or just the digestive surgical patients. And I would like to say also that in Spain we have a training program for residents and for training in this model of assistance. All right. So I don't know if I answered your question.
And there are no other questions on the platform. So unfortunately, our time is up. So I will close the webinar with some finally summary remarks. So multimorbidity, polypharmacy, but also current problems related to the lack of resources and beds can also mean that the surgical patients often have to be managed by the internist. The internist also appears to be the most suitable figure to manage the complex surgical patient, avoiding a fragmentation of care. So the internist should have specific tasks. Today is extremely interesting because there are many open issues that need to be defined if we want to start building effective co-management operative document for shared management resources, model, and the figure of the hospitalist.
Oh.
I think she's disconnected.
Yes. Oh, yes, yes,
As a specialist, capable, complex patient are consolidated. And okay, I have some problem with my connection. Sorry. And so, in conclusion, the European Scientific Society considers the topic to be a great importance, and we hope that further opportunities for discussion on this topic will be organized. So thank you for your participation. I thank the speakers for their important contributions, and I wish you all a good evening. And we hope to see you at our autumn webinar on the EFIM Academy web platform in autumn. Thank you, everyone.
Thank you. Bye.
Thank you very much. Thank you.